In the last section, we'll talk about a different type of hemorrhagic stroke, which is called subarachnoid hemorrhage. In the picture here, you can hopefully see that the subarachnoid hemorrhage involves bleeding on the surface of the brain rather than inside of the brain, as we saw with intracranial hemorrhage. So subarachnoid hemorrhage is the least common of the hemorrhagic stroke, but it's when a vessel on the surface of the brain ruptures, again as shown in the circle here. It's usually due to aneurysms where the vessel wall gets weaker and can rupture, causing blood to collect on the surface of the brain. The blood then fills the subarachnoid space and the ventricles and increases the pressure on the outside of the brain to cause symptoms. So the hallmark symptom of subarachnoid hemorrhage is the worst headache of your life, is what patients describe. And you can see this occurs in many patients, almost 80%. Other things that you can get are stiff neck, nausea, vomiting, and altered level of consciousness. As far as mortality goes, not quite as high as with intracranial hemorrhage, but still, 25% mortality, and about a quarter of these patients will die within the first 24 hours. It does cause a lot of morbidity, just like intracranial hemorrhage, so about half of survivors will have persistent neurological deficits, and a third will require lifelong care. What are the risk factors for subarachnoid hemorrhage? Well, again, just like intracranial hemorrhage, hypertension is a big one for patients, but the others are listed there. Also, as your age increases, particularly as you get above the age of 50 years old, that can increase your risk also. So once you develop a subarachnoid hemorrhage, what are your treatment goals? Just like with intracranial hemorrhage, you want to stop or slow the bleeding. In this case, surgical intervention is really the gold standard. All of the medications that we'll talk about are really adjunctive or alternatives if surgery is not available. So just a brief overview of some of the surgical options. It's called clipping or coiling. So clipping is what you see here on the left, and this is basically where you take, it almost looks like a paper clip, and you squeeze it around the aneurysm site. This stops blood flow into the aneurysm, but it is a more invasive procedure. It requires them to actually cut open the skull, and the clip will remain in the brain afterwards. Coiling, on the other hand, is a procedure that's become more in favor because it's less invasive. It's inserted through the femoral vein with fluoroscopy, and basically the coil is just threaded up to the side of the artery, and it eventually kind of clots off and seals off the opening of the aneurysm. This is also left in permanently, but because it's less invasive, if the aneurysm is in a site that's accessible, coiling is the preferred method. So as I mentioned, medications are really intended only to treat the complications of subarachnoid hemorrhage, one of which is rebleeding. So we mentioned, once you have a subarachnoid hemorrhage, about 20% of patients will bleed again, and this is typically within the first 48 hours, but it can happen up to 14 days afterwards. The primary treatment, just like before, is going to be surgery, either with clipping or coiling. You can consider using an agent called aminocaproic acid, or the brand name is Amicar. This agent works by blocking the activation of plasminogen. So this essentially inhibits fibrinolysis and helps stabilize your clot. Its place in therapy is really just to consider if you can't do surgery for whatever reason, if patients have a very high risk of rebleeding, and no other contraindications to receiving the medication. Hydrocephalus is another complication. This is where you get accumulation of excess cerebral spinal fluid, or CSF, in your ventricles because the blood is blocking the CSF from flowing out of the brain through the ventricle space. This can happen anywhere from the first 24 hours to a few weeks after bleed, and this really is, again, a surgical intervention. So they can actually put drains or shunts in to help the CSF flow out. The last complication that we'll talk about is vasospasm, and this is something that you actually can use drug therapy for. So what is vasospasm? As you can see in the bottom right of the slide, you have a normal artery with good flow, but they have seen in patients after a subarachnoid hemorrhage that the artery tends to vasospasm. So you can imagine in the bottom where the artery is squeezed closed, you're not getting good blood flow to the downstream areas. So what you can see is that when this occurs, you do get delayed ischemia, and it can cause new neurological deficits in patients. And this accounts for a high amount of mortality and permanent neurological damage, in addition to what's already been done in patients with subarachnoid hemorrhage. The onset is typically within the first 3 weeks after a bleed, but most commonly occurs within the first 10 days. And you can see it affects quite a lot of patients, 30 to 70% overall. Nimodipine is a calcium channel blocker. The brand name is Nemotop. It works just like other calcium channel blockers, but it does seem to be more specific for the cerebral vasculature. Just like other calcium channel blockers, its main side effects are hypotension, but can also cause headache and nausea. It's actually only available orally in the United States, and it's dosed as 60 milligrams orally every 4 hours for 21 days. You can also give liquid down the nasogastric tube. This is started within 96 hours of the subarachnoid hemorrhage, and it's thought to be so important for preventing vasospasm in patients that if patients do develop hypotension, we, instead of stopping it, we actually just try to decrease the dose, maybe to 30 milligrams every 4 hours, or trying to give 30 milligrams every 2 hours if patients are hypotensive. We feel it's just important to keep something on board with nimodipine. Why do we think it's so important? It's really recommended for all patients for prophylaxis of vasospasm because it has been shown to decrease the incidence and severity of neurologic events and improves neurological outcomes. Magnesium is another therapy that's been studied for vasospasm. Magnesium does relax smooth muscles and cause vasodilation. So this is given as a continuous infusion, usually between a half to a gram an hour. And you do target a higher magnesium level than normal, so up to 4 milligrams per deciliter, with a general maximum rate of 2 grams per hour. Some of the side effects of a lot of magnesium is it can cause CNS depression, so patients are kind of sleepy, drowsy, and muscle weakness. Some of our nurses kind of refer to them as just rag dolls. They're very kind of floppy when you have so much smooth muscle relaxation. It can also decrease blood pressure. So place in therapy, compared to nimodipine, magnesium has questionable efficacy. Some studies show benefits, some don't. So it's really considered as an add-on therapy for patients who seem to be having vasospasm who are already on nimodipine. Of note with vasospasm, it's not something that we monitor for, can do imaging studies for. It's really based on whether patients start to exhibit new neurodeficits. After their subarachnoid hemorrhage, we assume that they're having vasospasm. Another treatment option that's mentioned in your book is called Triple H therapy, and this refers to hypervolemia, hypertension, and hemodilution. So what exactly does this mean? Hypervolemia means, give extra volume, and the thought is, give extra fluids, keep the central venous pressure at least normal to a little bit high to help increase blood flow to the brain. Hypertension, target a higher systolic goal, 170 to 200. Use vasopressors if you need it, again, to help maximize blood flow to the brain. Hemodilution was a thought that, if your hematocrit is too high, it can make your blood thick. And so, again, it would negatively impact your cerebral blood flow. So keeping a good, moderate hematocrit range was thought to be the best way. In practice, I'll say triple therapy is more like EH. So rather than hypervolemia, we target euvolemia. So a normal CVP or a normal wedge pressure, again, just to make sure that the tank is full, but not overly full. You do want to avoid dextrose solutions in patients with any kind of head issue like a bleed. This is because dextrose is free water, so it's going to redistribute and increase your intracranial pressures. You want to use things like normal saline that are at least isotonic. Hypertension. Rather than targeting a goal of 170 to 200, now we feel like a goal of a systolic less than 160 is probably good enough. If you are less than that, consider vasopressors or inotropes, again, just to help maximize blood flow. And we really don't do hemodilution. If somebody's hematocrit is too high, you're not going to bleed them out to make it lower. So really just focus on euvolemia and keeping your blood pressure in a reasonable range. In contrast to nimodipine and magnesium, which are used more for prophylaxis of vasospasm, Triple H, or kind of the revised EH therapy, would be more for somebody who's already got vasospasm and you're actively trying to treat them. Seizure prophylaxis. So about 6 to 18% of patients with a subarachnoid hemorrhage will have a seizure, in the immediate period. So there's been some interest in giving them anti-epileptic medications to help prevent that. Phenytoin has the most evidence, or Dilantin. I'll refer you back to your other lectures about phenytoin, but essentially, it's got complicated pharmacokinetic parameters, and infusing it at fast rates can be dose limiting because of the hypotension. Because of that, we've had more interest in using phosphenotoin, or Cerebex. This again can be infused a little bit faster. Valproic acid is, of course, another anti-epileptic. This has been shown to have negative outcomes in subarachnoid patients, so we tend not to use that unless they're really having refractory seizures. Keppra, or levetiracetam, is an agent that we've gotten more excited about using, again, because it's much simpler to dose. It doesn't have a lot of the pharmacokinetic issues that phenytoin does, drug interactions, and side effects. There's really not a lot of data for one agent over the other in this population, so I think Keppra is gaining more popularity. The question as far as how long to treat these patients, some people recommend a week, some people say a month. It really depends on the provider. But long-term use is really not recommended unless a patient has risk factors such as prior seizures. So in summary, for subarachnoid hemorrhage, just like intracranial hemorrhage, you really just want to stop the bleeding, and that's primarily going to be with surgical intervention. As far as preventing complications, such as rebleeding, again, this is going to be surgery. Hydrocephalus is going to be a surgical intervention. And cerebral vasospasm. So we talked about prevention with agents like nimodipine, maybe magnesium, and then trying to make sure patients are euvolemic and have a reasonable blood pressure to maximize their cerebral blood flow. Supportive care is very similar to intracranial hemorrhage. You do want to control the blood pressure in both the acute and chronic phase. Seizure prophylaxis is indicated for subarachnoid hemorrhage. Evidence for benefit in patients with intracranial hemorrhage has not been shown, so it's not recommended in intracranial hemorrhage, but you do it in subarachnoid hemorrhage. And as before, try and avoid big highs or lows in your sugars and other good ICU care for the patients.